Hello, this is Dr. Max Fung, University of California, Davis in Sacramento, California. This is the annual introduction and orientation for dermatology and pathology residents. For the full curriculum, please check our website and feel free to leave feedback or comments. Now, before getting caught up for the rest of the year, or 3 years, with the many intimate details of diagnostic dermatopathology, I at least find it useful, if not nostalgic, to pause at the beginning of a year and at least consider a little bit of historical perspective, both for the profession or subspecialty of dermatopathology at large, and also for our local institution of UC Davis. So, dermatopathology. Some say dermatopathology, or how about just Dermpath? It's a relatively subspecialized area of medicine dedicated to the diagnosis and management of skin diseases via the microscopic evaluation and increasingly submicroscopic evaluation of lesional skin tissue. And unlike other highly subspecialized areas in medicine, Dermpath is not a new field. In fact, the modern day foundations of the fund of knowledge in Dermpath were created by physicians and scientists from many disciplines dating back to the 19th century at least, with predominant contributions from pathologists and dermatologists over the past century or century and a half, the likes of Savat, Gons, Curley, Pincus, father and son, and Paul Una. I particularly remember Dr. Una because I have a photograph of him on the wall in my office that was given to me by one of my former dermatology residents, Dr. Errol Craig. And in fact, Dr. Una was regarded as arguably the top dermatologist in the world in the early 20th century. He was the first to describe seborrheic dermatitis. He also described one of the types of melanocytic nevus, and you may also be familiar with his famous boot and his famous paste. But as you can see, in order to do an authentic history dive here, you do need to be able to read some European languages. My personal experience as a Dermpath history dilettante, emphasis on the latter, was facilitated by the first comprehensive U.S. Dermpath textbook that was published by Dr. Walter Lever when he was a fifth-year dermatology faculty member at Harvard in 1949. This is Dr. Lever in the framed photograph when he visited UC Davis in 1977 as our Novi visiting scholar. Standing to Dr. Lever's right is Dr. Larry Bass, the founding chair of our dermatology department at UC Davis. Lever's, I believe, remains the most comprehensive U.S. Dermpath textbook, now in its 11th edition. And I guess at this point I should say with pride that I do have a small scholarly conflict of interest here because I did co-write one of the chapters in the 11th edition. Not financial, though, I wish. I'll talk more about tissue staining and special stains in that intro lecture, but suffice it to say here that the accidental discovery of hematoxylin as a tissue stain in the 1800s, followed by the creation of eosin, and soon after the discovery of the hematoxylin and eosin, or H&E double stain, revolutionized the field of pathology and essentially formed the foundation of anatomic surgical pathology as we know it, including Dermpath. And it would be a vast understatement to say that this technology has stood the test of time, like a century and a half, and still going strong. I attribute the longevity to a winning combination of its superior ability to discriminate fine details within tissue specimens, combined with its rapid turnaround time and cost effectiveness. The 1970s and 80s saw rapid adoption of immunohistochemical stains, or IHC, as an ancillary diagnostic test, and in many cases essential for diagnosis. And we're now seeing increasing reliance and availability of molecular diagnostic testing. Skin specimens are obtained by a wide variety of doctors and providers in a variety of settings, but the dermatology clinic probably represents the single biggest source of skin specimens. The Dermpath waiting room is quite a bit more compact. Wet tissue specimens and prepared slides arrive daily. And sometimes it seems like we're more of a 5-star hotel or a medi-spa because our courier in her hybrid vehicle personally picks up and diligently transports each of the specimens to their appointment in the Dermpath waiting room. One by one, each specimen is accessioned, grossed, processed, embedded, cut, and magically slides appear on our desks, and the doctors and doctors in training view them under the microscope and render an interpretation. So in rendering a diagnosis on case after case after case, pathologists wield great responsibility and power, and that is par for the course in traditional surgical or anatomic pathology, AP, where histology is the diagnostic gold standard for most tumors, including skin tumors. Clinical correlation is still essential, and of course, with any technique, there are limitations. So some cases are simply challenging and beyond the range of what H&E can resolve. Alternatively, if one is perhaps asleep at the wheel for even just one case, there's a potential to make an error that could potentially result in patient harm. Sometimes a technical error could be quite significant, a wrong or a switched specimen. And then finally, we mentioned ancillary diagnostic testing, which can be decisive in certain cases, but typically the decision to test has to be recognized as being indicated based on the H&E. The other side of dermatopathology are the skin rashes or inflammatory skin disorders, in which the gold standard for diagnosis is not just the pathologic diagnosis, but rather a clinical path correlation. So one must know one's clinical derm. And molecular studies are playing an increasingly prominent role in the entire field of pathology. It's been said that such studies may even replace H&E entirely within the next few decades. This being a quote and also a photographic tribute to the first person who taught me dermatopathology as a second-year medical student and then later as a dermatology resident, Dr. Phil Lebois, founder of UC San Francisco Dermatopathology Service. And so for now, I'll leave you with this image for thought, if you will. Is this just an aging dermatopathologist's bad dream and the end of dermatopathology as we currently know it, or perhaps somebody else's opportunity for a Nobel Prize? Probably both. However, at present, I do not really see any impending end to the current way of doing things, which is that the vast majority of our diagnoses are in fact made definitively on hematoxylin and eosin, H and E stain sections alone, with occasional but critical assistance from histochemical and or immunohistochemical stains. Although Dermpath and H&E have been around for well over a century, the subspecialty is still relatively small in terms of full-time practicing dermatopathologists. UC Davis Medical School was founded in 1966, and it was not until '86 that Dr. Ronald Barr was recruited as chair of dermatology with a primary focus in Dermpath. Joining him was the late Dr. Philip Vogt, who stayed here for the rest of his career. After that, we had the amazing Dr. Beth Rubin. I arrived in 2002 and started the Dermpath service as we know it today. And of the 7 full-time dermatopathologists at UC Davis, 3 of them are still your attendings, myself, Dr. Thomas Konia, and Dr. Maya Kiiru. We also have an affiliation with the Veterans Affairs Hospital, where we have Dr. Joshua Schulman, an amazing teacher. We also have volunteer teaching from dermatopathologists in private practice at Diagnostic Pathology Medical Group. And there are many dermatopathologists who are board certified but not primarily focused on Dermpath. One of those is Dr. Peter Lynch, former department chair and distinguished Novi professor and program director. And Dr. Lynch was the one who kindly donated some of his older dermatopathology textbooks to me when he retired. The UC Davis Dermatopathology Service is a CLIA certified and CAP, College of American Pathologists accredited laboratory within the Department of Dermatology, located a few miles from the main UC Davis Hospital
and Medical Center at the site of an old cannery, now Cannery Business Park, or the Park, in East Sacramento. Across the street is the Roxy Delicatessen, which was featured in the 2017 film Lady Bird.
Heading inside, the good old days. This is how we used to do it, like most people did, with most of our teaching sessions occurring at our 16-headed teaching microscope.
And so since 2020, early 2020, it's been quite different. And as of July 2022, at least for this summer, we are continuing to rely primarily on remote learning. At the same time, we have this big, beautiful 16-headed teaching scope sitting here ready and available for use. So I think that for the daily teaching signouts, we're still going to encourage, whenever safe and possible, to conduct live previewing, at least one rotator that could potentially Zoom the previewing session to other rotators viewing remotely. But this can be a fairly fluid situation at this point, depending on the group sentiment and the makeup of the group. So this is our room. And I think in the first year, we were a bit more obsessive about the possibility of fomite transmission of COVID, but that doesn't seem to have panned out, at least nearly to the magnitude of the usual mode of transmission. So I still think it's a good idea to remember that there's a lot of touch points on the microscope, and this has been demonstrated for hospital and laboratory settings. And so the eyepieces and the handles, the platform, all get touched by multiple people, especially in a training situation. So it's a good idea to think about that and consider wiping down the microscope, including the eyepieces, before and after use. Here's a closer view of the teaching microscope, and I've surmised that in order to maintain strict 6-foot distancing, probably a maximum of 3 people at the scope at one time. Something like this, though admittedly, as was always the case, the viewing from the number 2 and number 3 positions being farthest away from the driver may be somewhat suboptimal in terms of the light density. We have 2 additional teaching microscopes that could be used by trainees working in parallel. Microscope number 4 is no longer in the photo. This is being used by our International Dermpath Fellow currently, but number 5 is currently available. And here is a closer view of the microscope itself, and just a reminder of the typical touch points on the microscope. We have the objectives on the turret that are handled, and then the slide being pushed with or without a slide holder on the platform. We have the focusing knobs, the subcondenser handles down here somewhere, and then also the eyepieces as the most frequent touch points on the microscope.
Our Dermpath service uses 2 different lab reporting systems. For UC Davis cases, we have the Beaker lab reporting system, which is part of the EPIC EHR. And then for outside cases that come from outside UC Davis, we have a separate system supported by Novopath.
Now for these 2 laboratory reporting systems that run in parallel, trainees will essentially only be using the first system, which is the Beaker lab reporting system that is electronically interfaced with the EPIC electronic medical records. And so all specimens submitted by UC Davis providers will be in this system and use a DC accessioning wheel in contrast to the SP accessioning wheel for cases that originate in the hospital pathology laboratory. And for cases submitted by providers outside UC Davis, we use the Novopath system with a DS accessioning system.
I feel very blessed that I've worked consistently with very conscientious and responsible colleagues and trainees. The one housekeeping thing to remember is that these little 1 by 3 inch glass slides are easy to move around, but just remember that they're part of the patient's medical record. And unlike the electronic records, they are essentially irreplaceable. So if you do need to take slides out of the Dermpath unit for whatever reason, please just check in with our admin staff and they can prepare a tissue release form for you.
All of the recent slides from the past several years are filed on site, and so you could retrieve those yourself or ask one of our very capable admin staff to retrieve those slides for you with a little bit of advance notice. And when you're finished with the slides, you don't need to refile them. Just go ahead and put them in this shelf around the corner from the main admin desk. Biopsies obtained from critically ill patients are marked for top priority, and it never hurts that if you write or mark on the comment section of the order that it's a rush or a hospital case, but our laboratory staff is well trained to recognize those specimens, and we will automatically prioritize those. Now, if you happen to be in the lab, if you are able to kind of just give the staff a verbal heads up as you're dropping the specimen off in the bin, that never hurts. And if you're off-site and need to contact the lab, you can always call the main number or get the backline for the laboratory from the orientation handout and call the lab directly to make sure that someone's going to be there, for example, if it's getting close to 5 p.m. on a weekday. And for number 3 here, I'm going to emphasize this because you're getting a lot of information overload in July of the first year especially. And once you're on the front lines and it's a critical situation, you're doing hospital biopsies, it's late in the afternoon typically when you see those patients, and maybe you decide you need to do a biopsy. So one of the things that commonly comes up with the hospital biopsies is infection. And of course, the patients tend to be critically ill. So one of the options that we have is to pre-order special stains for pathogens or bug stains. And so if you write rule out infection on the order, pretty good chance that our histotechnologists are going to recognize that and contact the pathologist of the day to make a determination if special stains should be obtained. But in the end, it's kind of a case-by-case decision. On one hand, sometimes you look at the H&E afterwards and realize that the special stains were never indicated. But on the other hand, if the index of suspicion is correctly high, then we are going to want those special stains to be more definitive about confirming or excluding a pathogen. And of course, this is most critical on a late Thursday or a Friday or before a long holiday weekend. So all those kind of factors have to kind of be considered in the overall composite assessment and the situational awareness. But this is something to keep in mind, that we do have the capability of pre-ordering special stains when there's a reasonable chance that it is going to be fruitful.
Weekend and evening stat frozen sections are covered, and they're actually covered 24/7 as needed by the Department of Pathology. The pathology residents should have the details in their resident policy and procedure manual. And this introductory lecture, when it was in person, used to be the first chance that you would get to see the people that you'd be working side by side with in the evenings or after hours when you had a stat case. Now, sometimes when a stat case happens during normal business hours and Dermpath is open, we're happy to handle that stat frozen section as well. Just call Dermpath, and more often than not, we'll be able to take care of that slide preparation. Your welcome packet includes a Dermpath grossing manual at the end. And in that, you'll see that the shave, punch, and excision specimens are the most common specimens submitted in Dermpath. The shave and the punch biopsies are relatively small specimens that can usually fit in a single cassette on a single slide, whereas the excisions and occasional incisional biopsies are usually submitted in multiple blocks sectioned in red loaf fashion. In the old days when I was a resident, and maybe still true at other programs, the residents on rotation were expected to gross the specimens. That's not the case in our program, but it's still very valuable to understand how specimens are grossed in the lab. So if you have interest in seeing that, just please contact one of your attendings and we'll arrange for you to observe one of our grossing technicians. When you're on the Dermpath rotation, you spend most of your time at the microscope, so sometimes it almost seems like the slides just kind of magically appear there. But in fact, there's a lot that goes on behind the scenes, not just the grossing, but several steps after that. So this text here is just a little bit of a snippet from the grossing manual that's been provided to you, and it just attests to the fact that there's a critical importance of accuracy at every step along the way, specimen after specimen after specimen. We have a team of highly skilled technicians working, sometimes it seems nonstop behind the scenes to get these slides to us promptly and accurately. Hats off to them. more snippets from the grossing manual that I won't dwell on since you have it. Although I have to say, looking at this, that I do see some of the words of wisdom from Dr. Philip Lebois from UCSF. He gave me a similar grossing handout when I was a dermatology resident there. Punch biopsies may be in a wide range of diameters. Probably 4 millimeter is the most common, but as you can see, there's a wide range. Whenever possible, we do prefer to bisect the specimens so that we don't lose any tissue and that the initial sections will be from the center of the specimen most likely representative. Grossing guidelines for shaved specimens are similar to the punch biopsies. Shaved specimens could be shave removals or shave excisions, in which case we would typically add ink to better assess margin status. The glass slide on the upper right shows breadloaf sections of an excision specimen. You can see the tumor at gross power in the top two pieces of tissue there, and the grossing diagram shows a top view of an excision specimen with the vertical black lines indicating the locations of the breadloaf sections. Typically, we put the excision tips in a block, and as you can see, B and C would be a second and a third block of this specimen. If the specimen was submitted with the orientation, such as a suture or a hash mark, then we would use two different colors of ink in order to preserve that orientation in the event of a positive margin. And less commonly received is the incisional biopsy, but it's worth mentioning here. These specimens may be an identical size and shape to an excision specimen, but in this case, the clinician is not looking for margins. It may be a portion of an inflammatory disorder, often a paniculitis or morphia. And so in that case, we don't need breadloaf sections. We don't need ink for margins. What we want is really just the best tissue sections that we can get. So these would actually be sectioned longitudinally so that we get single large tissue specimens as opposed to multiple breadloaf sections. Makes for pretty viewing and nice photomicrographs in the event of publication. Let's start to conclude with a few comments on your learning. Of course, you'll be continuously training through the Dermpath curriculum through your residency time here, but let's start with some of the resources that are available. And hopefully to you as digital natives, you won't find the potential for information overload here quite as whelming as a digital immigrant like me would. There's no shortage of dermatology, pathology, and Dermpath textbooks. Some of the ones listed here are just scratching the surface. Increasingly, as you can see here, some of these resources are online, and pretty much all of these textbooks generally nowadays have online versions for you to study from. And as I alluded to before, unfortunately, I do not have any financial conflicts of interest with any of these. I did write a few chapters in some of these books, but that's the extent of it. And currently, our program is providing the Elston and Faringer textbook here, this one right here. And so that's what the dermatology residents are starting with. But I find that many trainees over time then expand to other textbooks, depending on your level of interest. If you find yourself wanting to learn more about Dermpath, maybe even thinking about a possible fellowship application, it's a good idea to stay on the cutting edge of the field by reading the journals and participating in the Dermpath societies. The two largest journals are the Journal of Cutaneous Pathology and American Journal of Dermatopathology, and both journals are sponsored by societies who also hold national and international meetings in dermatopathology. Unfortunately, the upcoming ASDP meeting was converted to virtual, so we'll see how that goes. This is new and uncharted territory. The live meetings for ISDP in 2021 are still a go, pending further developments. We have hard copies of both of these journals in the teaching room in our Dermpath unit, and both are available through the UC Davis library as well. I think I've had some version of this slide in my introductory lecture probably for at least a decade, but I like to put this up at the beginning of the year because we have incoming trainees and also trainees who are graduating to the next postgraduate year, and I think it's an appropriate time as any to think about yourself, think about your training, your goals, your aspirations, and see how that might fit, whether that be Dermpath or some other area of dermatology or medicine. But here's some details of what could be construed as a hierarchy of competence in dermatopathology. And of course I put a question mark there because there's not a whole lot about this that needs to be rigid. One could say very little about this or discuss it for hours. So that will happen in the Zoom session afterwards. But at a minimum, as a dermatology or pathology resident, you are expected to pass the dermatology or AP boards. And as you surely know, the Dermpath component exists in both. So that's the minimum. Everything else is extra on your own, but there's lots of different things that can be done. If you complete a fellowship, then it opens up other opportunities. These are things that we can discuss individually or as a group in the Zoom meeting. And as we segue to the virtual discussion, I'm going to leave you with 4 scenarios to think about and discuss with me. I won't read them. You can look at them as fast or slow as you want. But here's the first one. Here's the second one. Here's the third scenario for discussion.
And a fourth scenario.
And finally, the last and perhaps most philosophical one. So I hope you found some useful information and resources from this introduction. Your Dermpath attendings here are very passionate about telling, showing, and involving you in the wide world of Dermpath. And we know that you'll forget some things, but also that you're going to remember and learn.